Hi. Hi, Professor Muharrem.
Hi, Muharrem. How are you? Uh,
Yes. Can you hear me
yes,
now?
yes. Welcome. How are you?
Good. How about you?
The Max IB has just connected. Uh, I think, Max, can you unmute yourself?
No, can you hear me?
Welcome. How are you?
I'm okay, thank you.
Good to see you. We have done a mistake that in some announcements it is at 5 p.m. with Turkish time. In others it is 6 p.m. So please apologize for us. And then I think since we have gathered many people already, we can start the first speaker and you can make the moderation, Max.
Okay. So, do I see the speakers? So, yeah, yes,
The first speaker is with us, Dr. Yahya Guvenc.
yes.
Muharrem is also here. The others will come by the time, I think.
Okay. Okay. So, welcome, Dr. Yahya,
Thank
and
you, Professor Abi.
I think you're going to talk about the classification and the clinical appearance of congenital scoliosis. I think this is a very complex issue, and there is always debates about classification. So we're looking forward to hear what you have to tell us. So
Thank,
please go
thank
ahead.
you. Thank you. Welcome again. I will try to explain a classification and some of clinics. We don't talk in this presentations treatment methods and surgery. The other speakers continue with surgery. I'm apologize for I'm in airport. We are going to do WFNS education course. Because of that, some voice maybe come outside. I'm sorry again. Now I will start. The scoliosis, when we look at the scoliosis, this is early onset scoliosis, adolescent idiopathic scoliosis, and adult degenerative scoliosis. We talk about the congenital scoliosis. We focus on that. And congenital scoliosis, it is a spinal deformity, occurs due to failure of normal vertebral developments during the 4th and 6th week of gestations. And sometimes assess for neural axis abnormalities, and prevalence is high between 1% and 4%. And when we look at the congenital scoliosis etiologies, there are genetic defects. There is some carbon monoxide exposure during the formation period, sometimes fetal hypoxia, sometimes gestational diabetes, and antiepileptic effect again, and prolonged febrile starts. And there are some associated anomalies: neurological malformation, congenital heart malformations, urological anomalies. Most of them is neurological malformations, and 35% of these patients has diastometamelia, or Chiari malformation, or intradural lipoma, or tether cords. And sometimes associated anomalies is congenital heart malformations. We can see 25% of the patients, pallotetralogy, transposition of the great vessels, and sometimes urological anomalies, 20% of the cases, horseshoe kidney, vesicular reflux, hypospadias, and inguinal hernia. And when look at the congenital scoliosis etiologies again and pathologies, some of the pathologies occur from the osteopathic vertebra, some of the occurs from neuropathic pathologies. Osteopathic vertebral and skeletal anomaly, failure of formations, failure of segmentation, and mix. We will talk again for this. And neuropathics are spinal bifida, tethered cord syndrome, myelomeningocele, syringomyelia, and Chiari-1 malformations. And this is the terminology. Formation failure, we can fully segment it. This is the hemivertebra, fully segmented. We mean we can disc adjacent levels at superior and inferior. This is fully segmented. And this is semi-segmented hemivertebra. There is a dissipate, but there is a fusion area. This is semi-segmented, formation failure. And non-segmented, this is non-segmented. There is a fusion in upper level and below levels. And there is a segmentation failures. For example, this is unilateral non-segmented bar this is. And this is block vertebra. Block vertebra, all of the vertebra is, there is a fusion, sometimes 2 or sometimes 3, sometimes more than 3. This is the terminology, and we will use in this presentation and other presentation. When we look at the classifications, there is a Winter classification. All of us know this classification because most used classification is that Winter classifications. It's written in 1966, and there is a failure of formations, and the second is failure of segmentations and mix. Failure of formation, we can see again, this is the wedge vertebra, this is hemivertebra full segmented, this is partly unsegmented vertebra and unsegmented vertebra. This is formation failures and segmentations failures. This is block vertebra, and there is a bar, and there is a bar and contralateral vertebra. But in during the time, we started to use 3D CT images, so we can see other anomalies at the anterior of the spine, sometimes only posterior of the spine. And sometimes we find new mixed vertebral anomalies. So we extend it to Winter classifications, because Winter classifications depend on use of plain X-ray images, and all formations failures don't encompass it in these Winter's classifications. And mixed category is when we use to CT 3D, we see a lot of mixed. So Imagine and et al. Classifications, they write new classifications, and they look at the anterior component of the spine, and they look at the posterior component of the spine. In anterior component, there is a hemivertebra, hemipedicle or butterfly vertebra, lateral wedge vertebra. Posterior component is fully segmented hemilamina, semi-segmented hemilamina, and in Winter classification we can see that and spina bifida, bilamina compliant or incompliant, wedge lamina, and accompanied with spina bifida. And Kawamarki classification again depends on 3D CT studies, and they write this paper in 29, and they divided congenital scoliosis 4 types. Type 1, solitary simple congenital malformation. We use this type 1 frequently in congenital scoliosis. For example, sometimes hemivertebra, sometimes wedge vertebra, sometimes butterfly vertebra. In type 2, multiple simple anomalies, combination of hemivertebra, wedge vertebra, and butterfly vertebra. Discrete, adjacent, or odors. And type 3, complex anomalies, mixed, and type 4, segmentation failure only segmentation failures. And then in 2015, some of the authors again make another classification, Bornei-Gavrilli classifications. And these classifications depends on coronal and transverse view of the spine, because they look at the longitudinal view of the spine and they find again in 3D images rotational imbalance. All the classifications didn't look at the rotational imbalance. This is differences between Bornei-Gavrilli classifications. And they divide to 2 main categories. One of them is longitudinal congenital scoliosis with longitudinal imbalance. For example, we discuss this in other classification again. 1, formation failure with or without fusion failure of the ossification centers. A wedged vertebra, this is. And there is a hemivertebra. They divided to the hemivertebra, segmented, hemisegmented, unsegmented, or successive. There are a lot of hemivertebra. And then hemivertebral body, and 2 segmentation failure, unilateral longitudinal bar. This is unilateral longitudinal bar. B, bilateral vertebral block. This is bilateral vertebral block. And 3, mixed failure. Hemivertebra and longitudinal contralateral bars. This is the hemivertebra and this is contralateral bar. This is hemivertebra vertebral block and longitudinal bar. This is bar and this is the hemivertebra and block vertebra. This is mix. And intermittence, there is a hemivertebra, normal vertebra, hemivertebra, normal vertebra. And alternate, again, this is hemivertebra, but there are a lot of normal vertebra between the 2 hemivertebra. And then they look at the congenital scoliosis with rotational imbalance. This is the congenital scoliosis with rotational imbalance. 1, spinal tractions affects. This means there is a between F5 and sacrum, there is a fusion area. So because of that fusions, the spine make rotations. Bone bridge with congenital transverse sacral synostosis. 2, spinal pushing effect. F5 transverse process again, apotheosis, and again, when children is growing up, the spine has rotations. 3, mixed effect. There is a sacral agenesis here with pelvis malpositions. And this is different from other classifications. And we should know natural history because this congenital scoliosis is different from the adolescent idiopathic scoliosis because this treatment time is different. Sometimes we make direct surgery. Sometimes we make decision with growing systems, and other speakers will detail and they will give information, detailed information about that. But in these presentations, we should know natural history because this knowledge need for making decisions for treatments. Important progressive potential of the scoliotic curve and the progression rate depends on type of the anomaly. In lateral bar and hemivertebra, there are different progressions. And we should know patient's age because this is affected the natural history. And the place of the curve is very important. This is different in main thoracic and thoracolumbar junctions. If there are more than one hemivertebra, successive or intercalary, the kyphosis will get severe. For example, curve progression is induced by an unequal accelerated growth on the side with a hemivertebra. And in the presence of longitudinal bar, progression is fast. And fully segmented hemivertebra, again, progression is fast. Segmented hemivertebra and contralateral bars, most progressive type. And the progression rate is about 10 degrees per year. And the curve progression rapidly in the first 5 years. Next, during the age between 15 and 14 years. This is a growing time of the spine. If the vertebra is butterfly vine, the spine is balanced in the frontal plane. But there is initially mild kyphosis present, and we should know in butterfly vertebra. And again, we should know fully segmented, hemisegmented, and segmented vertebra has different progresses. There is some examples. For example, adjacent successive 2 or 3 hemivertebra disposed unilaterally inducing short arc scoliosis. For example, unilateral 2 or 3 hemivertebra placed unilateral leading make long arc scoliosis. And there is a composite, sometimes hemivertebra, 2 symmetric hemivertebra in a 4 and 5 vertebral segment inducing an equilibrated spinal deformity, not requiring surgery. But uncompensated scoliosis, if the hemivertebra are disposed on a distance of more than 6 vertebrae, leading to double congenital scoliosis. And this is examples, natural history of the vertebra. This is successive intermediate vertebra with fully segmented hemivertebra, and the progression is high in this vertebra. And now we can talk with some clinics. For example, we can see here hemivertebra, and there is a disc space upper levels, and there is again this space inferior levels. And this treatment is simple, but we should know this is hemivertebra, and there is a complex anomaly, posterior arc, and there is a kyphosis. Sometimes these patients come to us with kyphosis. And this is again another case. There is a segmented hemivertebra, and this is 6 years old. Again, these patients come to us with kyphosis and sitting balance. And this is 6 years old. And this case, 9 years old. And when we look at here, we can see here bar and hemivertebra. And this patient has come to us for shoulder imbalance and body tilting at the right side. This is the clinic appointment to us. And this is another case. This case has here hemivertebra with fusions, the upper level. This is segmented, unsegmented hemivertebra. These patients come to us. This is 15 years old. Again, he come to us shoulder imbalance and body shape disorders. Only this is the effects. And this patient is 15 years old, She has diastometamia surgery, and she come to us with again shoulder imbalance and body imbalance and kyphosis. And when we look at these patients, 3D CT images, there's a lot of fusion block vertebra. 4 vertebra here, there's a block vertebra. At the same time, costa has a fusions. And here we can find hemivertebra. This hemivertebra has a fusion with block vertebra. This is thoracic block vertebra, and this is hemivertebra, partial segmented hemivertebra. This is our focus area, and this area is hemivertebra. This is fusion vertebra, and this is the kyphosis. This is post-operative images. Now this is case 6. This is 15 years old, and this patient has again diastometamelia and tattered cord. And this patient again has, this area is fusion block vertebra. This is normally this space, but there is a fusion in here, and there is a hemivertebra in here, wedge vertebra, sorry. And this wedge vertebra, again, there is a posterior fusion, this block vertebra. And there is again operation area. This is wedge vertebra area, and this is fusions vertebra area. And this is the case 7. These patients come to us again, shoulder imbalance, and there is differences between leg lengths. One of the legs is taller, the other one. And when we look at this patient, see the images, we can see here bar, there is a bar, and there is a hemivertebra, and there is a contralateral bar. This progression is very, very fast, and treatment is in early age and late time, like 15 years old. This is difference. This is wedge area, and this is the bar. This is the contralateral bar. And we will continue. This is case 8. There is this patients come to us kyphosis, and when look at the CT images, this patient has meningomyelocell history, and there is a open failure of failure of segmentations and failure of formation, sorry, here, because there is no posterior elements between L1 and L5. There is an open area. Because of that, this patient is paraplegic, but when she is sitting, the kyphosis develop, and we look at the 3D images. Is there any other anomalies? For example, in here, hemivertebra, and this patient has kidney anomalies at the same time. There is a kyphotic area again, and this is the vertebral area, wedge vertebral area. And this is again the same patients and postoperative images. This case is come to do us the difference clinic, because these patients come to us with open wound. This is the osteomyelitis, and she takes approximately 1 year antibiotics, but she don't heal from antibiotics, and there is a large open wound area, and there is osteomyelitis at the same time. Sometimes patients come to us like this, and sometimes we can see again in CT scan and 3D CT for CT, there is again failure of formations. There is no posterior element of vertebra at this area, and there is a here hemivertebra, but this occur because of the osteomyelitis, and this patient has again kyphosis. This is operations, and this is case 10. Again, this patient has myelomeningocele history and kyphosis. There is a very huge kyphosis. These patients come to us were sitting imbalance, which takes approximately 2 months ago. There is a hoop, and there is again formations failure. There is no posterior elements at kyphotic area. And this is the CT, 3D CT images. We check with 3D CT. We can find another anomalies here again. And this is postoperative. And this is the last case. This is the kyphosis, but this is congenital and at the same time neuromuscular scoliosis, because this patient has Ewing sarcoma at the same time. There is a hemivertebra here, and there is a cervicothoracic junctions, kyphosis here, and hemivertebra and wedge vertebra here. And this is the postoperative. And thank you for listening to me. And
Hello?
His connection has been lost, I guess. Yeah,
It's back. It's back.
he's back.
Yes, now I hear again. It was away for a few, maybe 30 seconds or what.
Uh, we can probably wait a few minutes.
sorry.
Yeah.
Thank you. Sorry,
Welcome back.
Wi-Fi is gone, and I join again. Sorry.
So that was quite an impressive presentation with all your cases, which you probably collect over the whole country, I assume. You know, this is quite, I think one of the most important message what you give is that there is no simple congenital malformation of the spine, or it's very rare. In fact, most of these malformations are combined with different pathologies at the spine, but also in other systems like the cardiac system or the urological system and so on. So it is this is a challenge, this pathology, you know, and this severe deformity is what you have shown. I mean, probably the majority of the spine surgeons will never address this. This is beyond their scale, because I think if you want to do this kind of surgery, you have to do it on a regular basis. You cannot just do one case a year or whatever, you know. So I think it was really very impressive what you have demonstrated. Are there any questions from the participants? No questions? You have any comments to make, Dr. Yahya? It seems that you are interrupted again.
Yes. I wanted to say only something. If we detect this deformity early, everything is simple for surgeon and at the patients too. It is very important to find this vertebral anomaly very early. This is my presentation's main sentence, I think. Detecting it early.
Mm-hmm. I will just, the next presentation, I will just start with this sentence. I prepared it exactly in this way, you know. You are absolutely right. So no other questions or comments from the audience? So then let me try to share my lecture. So where is my lecture? Share.
Öyle mi? Tamam.